Good morning, everyone. Thank you for allowing us to put together a presentation for you this morning on the cost casing of ASCs and EHRs. Just out of curiosity, before I do that, I'm the young guy on the panel with the smallest practice, so I'm going to be learning alongside of you. So don't think that I have anything good to say. Out of curiosity, how many of us are still using paper charts within our ASCs? So a few of you. Good, and good. Excellent. So I'm going to jump right into our conversation. I guess we don't have anything to disclose. I'd love to, but I don't. We are the small group. We have three ORs within our ASC as well as a procedure room. We do about 2,800 cases per year. We do have 14 surgeons credentialed out of practice. We just acquired a practice of 2 additional surgeons, but they don't join us because they live about an hour away and service patients in another hospital system that far away. We did open a single room ASC in the state of Maryland in 2010, and that's because due to CON regulations in Maryland, we could have a single OR, but we outgrew that, and so we had to partner with our hospital, and we expanded it into a 4-room OR in 2020. And if you guys recall, 2020 was a fun year related to COVID. But we have about 14 years of experience doing outpatient total joints very successfully. We do over 1,000 total joints a year out of our ASC, and we also have been doing outpatient spine procedures for 12 of those years as well. So a little bit advanced in terms of ASC utilization for total joints and spine. About 18 months ago, we were curious and we said, how do we figure this out? We're growing in size, but we have no idea what we're doing from a case costing perspective. We didn't have the tools in front of us. Yeah, on a 1-by-1 we could figure it out, but it took hours. And so we said, what do we need to do differently? And we transitioned from paper charts. We were using Advantix for sort of our revenue cycle as well as the scheduling piece, and we transitioned to SIS Complete. And we went all in. We pulled the Band-Aid off quickly, and it was difficult, but it was well worth the time. We now do all of our scheduling inside of SIS. We developed the first interface with SurgiMate for surgical coordination, taking out human error and introducing a more efficient way to schedule patients. We also do all of our nursing chart documentation all the way through the process. We do all of our physician orders as well as op notes within SIS using no transcription, templates, and Dragon only. All of our anesthesia documentation. We have some older anesthesiologists, and quite frankly, I thought that was going to be the hardest part for us. But now we have visibility into anesthesia as well as the billing components of anesthesia as we consider bringing that in-house. Inventory management through Envy, we went enterprise-wide. So not only in the ASC, but we also incorporated into the enterprise across all of our clinics, including physical therapy. So we now at a CFO level have access to all this data at a very high level. We're also doing all of our revenue cycle within SIS, and then obviously analytics, which I'm going to show you briefly here. Looking across 4 surgeons, I blacked out their names to recuse the innocent, so to speak. But you can see we started to get insight around what was the cost per case for these total joints. And you can see on the far right, there's somebody who's doing a little bit better, and that's actually a less expensive implant that we're using. Looking at this slide, it's a sports case. 2 different surgeons doing the same case. And we paused and said, what are we doing? And the blue is the implant cost, the orange is medication, and green is supply. If we had to guess, we now know that this guy on the left-hand side is our #1 in work RVUs at the ASC. He's #2, maybe 3, depending upon the year in terms of revenue for the ASC. But thanks to our data, we now know that he's #5 in profitability. And you want to talk about the squeaky wheel who thinks he drives revenue, and now he knows he's #5 in profitability? We took the squeaky wheel and we turned it into a flat tire. What we've been able to do through crucial conversations, however, is we've had that difficult conversation with him, who happens to be a consultant for said blue company. And we had a very difficult conversation with him and said, hey, we love having your cases here. You're a great surgeon. You're very efficient. But ironically, because of your efficiency, you're actually losing money for the center. To Dr. Smith's point yesterday, highly efficient surgeon, talented guy, but he's actually losing money. That did not go over very well for him because he had a huge ego. Remember, #1 in work RVUs, #2, maybe 3 in revenue for the center. And so we had good conversations with our vendor, and I can share that we've saved over $100,000 because of renegotiation around implant costs, and also maybe we're not using as many allografts as we used to. Imagine that. And so these are early data. Our data looks much different today, but I want to share with you what data can do for you in your ASC. It's stuff that we had no visibility before. We found it tremendously helpful. We dig down into the per case, looking at total shoulders for us, because it's new to us this year, right? We understand what's going on. And you can sort of see, we get at the very end of this slide, we have profitability within each case level. We got supply costs, staff costs, et cetera. And I highlight the red there because it's implant costs. All of us know, well, at least I hope that we're not overpaying for implant costs over total shoulders, but $1,700 isn't correct. And so it allows us to quickly go in and look at that very specific case and say, our staff forgot to put in the implant costs associated with this total shoulder. So it allows us to quickly go in, look at our data, recognize that there's values that we're missing, and correct it, and so we can get more accurate numbers. Again, very, very efficiently now that we're no longer on paper. I share this slide briefly because it's, again, protecting the innocent on the left-hand side, but this is actually a slide I showed during our board meetings with our shareholders. And for you, the blue side means that we're scheduling cases, the scheduled cases that we thought it was going to take for a surgeon are 15 minutes less than expected. The green is where we want to be. It's a sweet spot, plus or minus 15 minutes of scheduled case time. And then on the far right, it's the orange, which is cases that exceeded what the surgeon expected for their case time. All of our friends who are nurses in the surgery center are barking up the tree about the orange, because that means their day went a little longer than anticipated. I look at this slide and I look at the blue and say, we missed great opportunities to service one more patient at our surgery center because we lost out, because we didn't schedule our cases as we intended. So again, just want to make sure that we focus on both sides of the spectrum. And again, that's what data can do for us. In closing for myself, considerations, last year we heard David Friedman speak about high-performing cultures. And I went home, read his books, talked to him for a bit, and then they came on site and actually introduced some concepts for us. I'm going to share a couple here, what we learned through that experience. We created fundamentals, as he suggested. POA way number 21 for us is be curious. And again, we're about week 23 into this 30-week session for us. 21 is be curious. And so as you think about your surgery center, be curious about not only your workflows and your daily activities, but also look at your financial stuff, the data that your product is producing. If you're on paper, strong consideration of going to an EHR that brings visibility. Again, we paid for our EHR system just in the first year because of the data that we now have access to. The second part here is the quality of the answer is dependent upon the quality of the question. Just pause and think about that for a second as you are curious about your data. The quality of the answer is dependent upon the quality of the questions. So make sure you're asking the right questions. Put thought behind your questions before you run down rabbit trails that have no meaning. Understand what you're looking for. Make sure you're paying attention to detail, because that little detail actually matters. I'm a small center. These folks are much larger than I, so I can get away with a little bit more error, because those errors compound in time. Assume positive intent. When you find something that doesn't make sense, make sure you have positive intent when you go to your surgeon and say, hey, how can we work together? Make sure that they have the same interests that you do. Practice blameless problem solving. Remember, it's not about the individual, it's about the problem in front of us. Keep it objective, content related. Make sure that you're working through the problems together. Do what's best for the patient. Make sure at the end of the day, implants are implants, but the reality is there's not much different between the vendors anymore. Sure, we got some innovation that happens on an annual basis or a monthly basis, but remember that most implants are very similar. Act like it's yours, be good stewards of what you have. I ask all of our surgeons, make sure that you're being good stewards, and all of our staff in general. But maybe, most importantly, make sure you're having fun throughout your day, because if you're not having fun, work's not worth it. This life is too short, so make sure you enjoy doing what you're doing. Last but not least for us, we simmer it down to data, discussion, and decisions. We try to prevent the emotional conversation, and we back it up first with data, because sometimes we think what we think, and it's not what it really is. So we always look at data first, then we have a discussion, and then we make decisions. And remember, I talked about technology here, but it's not technology that makes good decisions. It gives us the data to understand how to make good decisions. Our shareholders still need to make those good decisions with us. So with that, I'll hand it over to Beth.
Thank you. So I'm with Ortho, Tennessee. We have 2 surgery centers. My center, Knoxville Orthopedic Surgery Center, opened in January of 2010, and today we have 9 ORs. They opened with 5, 2 shelled in, opened those 2 pretty quickly, 1 procedure room. And then when I started in 18, we had just started construction on 2 new ORs to bring total joints to the ASC. And then, interestingly enough, like a couple of years ago, maybe last year, we made our procedure room into a real OR. It was not officially behind the red line, did not have a scrub sink, so we couldn't really do surgery cases in there. And as physiatry cases were moving to the office, the doctors hated seeing that room sit empty, and so we had to figure that out. So now we officially have 9 ORs. And it can be used as a procedure room and or a surgery room now, which is obviously more efficient. We do about 11,000 cases a year. We've gotten up to about 12,000, but as we've seen more physiatry go to the office and bigger cases come to surgery, we've dropped back down to about 11,000 because obviously the surgery cases take longer than the physiatry cases. We have 38 credentialed surgeons, but we only have 25 of those actually have block time with us. We have some random peds and spine and physicians that are actually with UOSC that are credentialed with us, but they don't routinely do cases. And then UOSC is the newest Ortho Tennessee Surgery Center that opened in July of 22. They have 7 ORs, opened with 5, and then have just recently opened 6 and 7. And that they're now slated to do 5,100 cases this year, and they have 30 credentialed surgeons. And there are some surgeons that go to both facilities. So for us at KOSC, we've always been on EMR, started with CIS product in the beginning, which was Vision, moved to AMCI, and then we're now on CIS Complete like Kimule. We moved to CIS Complete when UOSC opened because we wanted to have both centers on the same platform. In the event we shared staff back and forth, or billing, we may have billing people that could do things for both centers, and so we wanted that to be the same. And so we utilize all the things that you use. We have the CIS Analytics, which is an amazing platform. We have a lot of data there. We've done case costing for years. They were doing it when I came, and we've amped it up over the last several years. And we'd gotten to the point where we needed a little bit more of a deeper dive into it, and that's when last year at this meeting, Becky and Porter presented on Avant-garde, and Tammy and I sat beside each other and we're like, yeah, we're talking to him when we're done with this session. And so we were the first to sign up with Avant-garde with a CIS product. And so they are now able to integrate with CIS and with HST. And so this is an example of a case costing screen inside of Avant-garde, and so it's very similar to the CIS Analytics. And so it shows you the personnel cost, supply cost, and then they're able to show us the percentiles across the nation that we can compare ourselves to other hospitals, other HOPDs, ASCs, and we will eventually be able to compare ourselves to just Ortho Forum centers. And so that's exciting for us. And I'll pass that on to Becky.
Good morning. I'm Becky with Center for Sports Medicine and Orthopedics out of Chattanooga, Tennessee. Porter and I, again, presented last year, and it's the system with Avant-garde and our internal case costing have moved forward exponentially since we were here last year. So we're excited to give you kind of some updates. Just as a reminder, we have 10 ORs. We opened our new surgery center in July of 2023. We're currently on track to do 7,730 cases annually. Our doctors flip rooms, so if that helps you as far as the numbers. We have 20 credentialed surgeons. We are on HST. We went live on HST before we went into the new facility when we were in our older facility with 5 rooms in January of 2023. We use their cost management report and the cost report data analytics. We download that weekly, and we have a team, including our DON, our ASC administrator, Laurie, and myself, and we look at every case. And for any outliers, we download into a pivot table that can make your eyes crossed. However, what was so interesting is the first time we felt comfortable when we had enough data that the sample was large enough and we could get it in front of the physicians, our phones, it was an evening meeting, and all 3 of our phones were blowing up that night with doctors who had questions because they wanted to know why they were the outlier. So we started seeing change pretty quickly, especially when we were able to get some of the Avant-garde data in front of them because it's easier to read than a pivot table. And doctors, as you know, they like that visual visual information where they can see where the outliers and the ones, as competitive as they are, that are doing very well. So we have weekly meetings with the CSMO team, and then we present the reports monthly to the physicians. And to this day, we still get phone calls every single time we send those out. So the benefits is we added Avant-garde in July of 23, but it provides objective data for the physicians. There were things that we knew before we were able to start doing our case costing. We had a feeling this was going on, or we kind of thought this, but we weren't moving the needle with that. And so once we could get that objective data in front of the physicians, we started seeing the needle move exponentially. It's helped with our contract negotiations because we can go knowing exactly what our cost is down to, our administrator says we know down to the cotton ball what our cost is, and so we can stand firm with our with the BUCAs, and it provides accountability for us as managers as far as what we're doing and staying accountable to the physicians. So at this point, Laurie is the person that presents everything to the physicians for us. So we've asked her to show some of the things that she's presented and some of the things where we've made some big changes.
Good morning, everyone. This is a snapshot of the report that we download out of HST into Excel and drop into a pivot. And we're really manipulating this data to give us an average case cost. And we do sort this by the primary CPT, so we know there's some variances with some of those procedures. But this is pain. When we were first able to extract the case costing data out of HST, pain kind of bubbled to the top because we could see a drastic variance in costs from provider to provider. So in this example, this was in March and April of 23. Dr. B has an average case cost of $1,046 for the 64635. And for the 64633, he has an average cost of $1,034, where our other provider has an average cost of around $400, $450. That's a pretty drastic variance. So what we were able to do at that point is go back and look at preference cards, look at what was being assigned to the cases, what was actually being utilized during the case. And then fast forward to August of 2024, we're now running an average of around $300 for both providers, and a little over that for the 64633. Another advantage that this data gives us is looking at staff cost. So in this example, we've got one provider that has a slight higher case cost than his partner. And the reason for that is that one provider requires an extra staff member to be in the OR room with them. But we're able to show that cost variance to the providers. Next, we have a sample of vendor utilization out of Avant-garde. The data that we extract from HST gives us, implant costs, supply costs, OR times, it gives us these key points. The one piece that it was difficult to drill down to was actual vendors, the vendor utilization on each case. So when we saw Avant-garde, when we saw this product, it was the missing link to this data. So now we're able to look at the vendor cost for hip and knees and show the providers that we have an outlier. We are, when we built our facility, we made the decision that we wanted to be a Stryker facility with few exceptions. So this allows us to present the data to the providers to see that we have, one outlier here. Same viewpoint here by vendor, but for upper extremity. So again, you can see where we have outliers.
That's where we get the phone calls from those outliers. But then, some of them still feel strongly about the other vendor, and we're not pushing them otherwise. But it does get quiet to where you can hear a pin drop when these flash up on the screen. Mm-hmm. So While Porter's getting ready, I will say that since last year, there's been, we've worked side by side with Avant-garde's team, and they've made amazing steps forward, working collaboratively with us to make the data very relative for ASCs, because what we presented last year, we were being compared to hospital systems because they didn't have enough data. And so what we found is often it was hard to make that relevant when you're comparing your cost with these huge hospital systems that have the buying power that we don't. So as you know, we've progressed through 12 months, and I think we've got multiple forum groups now on Avant-garde. We're quickly moving towards just being compared to ASCs, and then even further, the plan, as I understand it, is for Ortho Forum ASCs, which is ideal because part of our model is benchmarking with each other. So we've been really pleased with that because we know it's meaningful data that we're getting in front of our physicians.
Yeah, we appreciate the help on the product development. Things we didn't know that we didn't know. So thank you to both centers for that. High level overview, the TD-ABC methodology is what powers a lot of our product and also what, the whole idea behind case costing and looking at personnel costs, and that was born out of Harvard Business School from the research that Michael Porter and Bob Kaplan did. So to steal a phrase from Karen, let's make accounting fun. TD-ABC is just a fancy word for healthcare accounting to understand exactly what you're paying for everything, supplies and people. And I will highlight, we're paying the people no matter what, right? So I think really that people cost is a proxy for operational efficiency. You're spending a lot in the OR on people, it's probably because you either have too many people or you're spending too much time in the OR. So what variable do you need to flex on? So it's really just a proxy, as I said. Salaries are salaries and they're going to get paid, but you really want to understand how much you're spending on people on a per case basis so you can understand the operational efficiencies by physician and by case. We wanted to give just a high-level overview of the variability of EBITDA margins within the ASC space. As you can see on that far left, that's the 25th percentile. And in the 25th percentile of ASCs, they have about a 15% EBITDA margin. And if you go all the way up to the 90th percentile, now you're sitting at a 42% EBITDA margin. So there's a big variability in profitability that's being returned to physicians, to stakeholders, owners, et cetera. And going back to the accounting, I think the great thing about TD-ABC is we don't want it to be just accounting. It needs to be actionable accounting. So numbers that we're seeing that we can actually then implement, see cost savings or revenue generation from. So there's obviously, wherever you may sit, I'm guessing there is some opportunity to get to that higher 42% EBITDA margin because some people are doing that. So we wanted to actually frame this, trying to make accounting fun. What are strategies that you can be using to become more profitable, all the while maintaining quality and clinical effectiveness? But all powered by this TD-ABC and cost accounting methodology. So looking at some of these strategies, decrease supply acquisition costs, optimize supply utilization, improve OR utilization. So that goes back to the people cost and understanding how much is being spent on a per case basis on people. Ensure timely revenue collection, manage case mix and contribution margins, leverage technology, and right-size the initial facility build. These are the ones we will focus on. Some of them aren't quite applicable to the data that we're going to be looking at. So looking at decreasing supply acquisition costs, very important to understand just how are you being paid? Is it a cost plus model? Is it a bundle? Is it fee for service? And then also looking at benchmarking. Do you have the ability to actually understand what are other people paying? What are you paying? And then aligning with the physicians. this is just a fancy way of saying, let's figure out what do the physicians actually like to use? Can we decrease the overall mix of that particular product category? Let's benchmark, and then let's renegotiate. We love the renegotiation because it doesn't change anything in regards to clinical practice. Obviously, unless you have 10 of one supply category and you're trying to drop that down to 3. But that's where having the physicians being participatory in that process is important. So Becky and Lori, the next two that we're going to show are two opportunities that have been looked at simply on renegotiation, and we'd love to just hear how you've looked at each of these and what does that process, contain, involving physicians, are we going to do it or not, et cetera.
Sure. So with this particular example, we saw the Avant-garde data as far as what we should have been paying, and then what we were paying. And Amy, by shake of head, is this the one where we did the thing that you were, okay. So we had these really fancy hoods that would come over, and they were much more expensive. And we had not even priced the ones that, for those of you that are clinical in the room, that are just like a Velcro and can pull across and for your total joints. And so in one of our Avant-garde meetings, they mentioned that this was a huge savings opportunity for us. So Amy, our administrator, immediately got in touch with our vendor. We got it in front of the physicians, and it was kind of just a no-brainer. And so we switched that immediately. It was absolutely nothing clinical. And we were able to save, dollars with just that negotiation.
I don't think we have a flight hood vendor here, but almost everyone we work with, we see overpricing in this very simple category. Should be paying around $20 to $22. So whatever you're doing right now, go look at your charge master and start renegotiating that price.
Easy low-hanging fruit and a huge win.
Yeah. And remember, all of this goes just straight to the bottom line. $89,000 may not seem like a huge lump sum up front, but it's a little time up front to renegotiate, goes straight to the bottom line, and you're going to see that $89,000 of savings year on year, not just year one.
Oh, yeah. Okay. So see, again, we meet with Avant-garde at least monthly. It's a short meeting, but they point out opportunities that they see for us. And again, this was one where it looked like that our pricing was just was higher than what it should have been. And at first we were very nervous because we were like, okay, but you're comparing us to hospitals. Well, then they were able to start honing in as we got about 6 months in, and we were like, no, this is other ASCs too. So again, we went back and we were able to renegotiate this to get our pricing down. No change for the physicians, just a change in the price.
So Becky, I'm curious because we did also recommend changing some of your suture anchor usage. Tell us how that went and then why we went to this model instead.
I don't know. It was a bromance with the suture anchors. I'm not exactly sure, but anyway, we didn't make a lot of headway there. I will say on the slide that Laurie presented, as far as with our pain, that one implant cost, we had that feeling with that one particular pain doc for years. We knew he was paying more for the supply cost for the exact same procedure than what his colleague was. But the very first night we presented that, and he stood out, I think it was the very next morning that he was in Amy's office saying, I'm going to need to try the Stryker one. Can you get a couple of samples? And he moved immediately. So it's just getting that data in front of him.
And I think as Becky mentioned, not everyone wants to switch, and I don't think we need to be forcing anyone to switch if they don't want to. So then go to the other option and just renegotiate. Get that price down and say, fine, you can keep using it, but we will save some money on the top through the renegotiation.
And 99 times out of 100, the doctors are doing the negotiation for you because they don't want to show up on these sheets every month when we're having this peer review, as we'll call it, in the physician meetings.
All right, so Beth, jumping to you and looking at antibiotic-infused cement, I liken this unto the flight hood as well. Seems like everyone's overpaying for it.
So we are not quite as far along as Becky that we have not presented this to our physicians yet. We are still working with Avant-garde monthly to get to a point where we're comfortable with the data that we're going to present to them. But this would be one of the first, in addition to the flight, because we're in the exact same place that Becky was. that we will get in front of our total joint guys.
So another announcement, you should be paying around $230 to $250 for that. That's just the price in the market. That you should be paying. They'll want to charge more.
Well, and that would be the renegotiation price. There's probably bigger savings if they don't use the antibiotic cement at all,
Yes.
which is a bigger conversation. We know the data doesn't really support that, but they, for whatever reason.
And then Beth, one other item that we saw was the complete knee implant. I will highlight that I think it's very important to be looking at the all-in construct price and not the individual components. So spend time getting that put together and looking at, what does everything all in look like, and be renegotiating on that. Otherwise, you're going to enter this, okay, fine, we'll sell you this portion of it for much cheaper, but in spine we see this a lot. Your spacers are a lot cheaper, but now we're going to charge you $800 for a couple pedicle screws, and in the end, your construct price is the exact same. You may feel better, but it's not changing your finances. So put that together, then go to the vendor and be renegotiating that all-in construct price.
Yes, and we are actually looking at this now and talking with the vendors about a renegotiation. We do have construct pricing on all of our total joints, and so it doesn't look like a huge number when you see the $2,960 to $3,200, but overall that's a huge savings annually.
So now looking at supply utilization, high level, we're just exactly what Becky said. I like to look at this as clinical appropriateness, maybe a better phrase for that, and really understanding what needs to be used, when it should be used, and matching that up with medical literature. Obviously, there's a lot of things that can be used just based on training, based on habit, but being able to actually prove that out in a clinical manner is important. So Beth, this is the antibiotic-infused cement that you were mentioning.
Yes, so we obviously have one surgeon that's a big outlier. Even if we could make change just with him, that would still be a big savings for us. One of the things I always tell my physicians talking about clinical appropriateness, I never tell them that they can't use something at our center, but if they have to use it, then they may have to go to the hospital. I mean, I'm not telling you can't use it for a quality reason, you just can't use it here.
Yeah.
Sorry.
No, I think that is interesting. And to give you a feel, I think you all know, call it 300-ish that you may be paying per unit of antibiotic-infused cement, and normal cement's what, $23 to $30. So it makes a big difference. Medical literature does say that it doesn't need to be utilized in every single joint replacement. We're working with BILH, and they have a system of 10 hospitals and a few ASCs, and it was the same thing. Everybody's using it every time it's available. Why not? So we spent a lot of time going through a physician committee to create usage guidelines. And so getting all these physicians together, deciding when it should be used, so they came up with specific BMI and hemoglobin A1C levels, et cetera, when it should and needs to be used, and then the guidelines of when you definitely just do not need to have that in the OR. So that's one way of doing it. We've also seen in Mayo Clinic's famous, they just take the normal cement and add a few drops of antibiotics into it. Whether that works or not, I don't know, but a couple drops of antibiotics cost pennies, and so they're saving quite a bit. They just all have their mortar and pestle in the OR. So different ways to skin the cat, but I think it's interesting to be able to look at that and understand how that rolls into the clinical care. And then this is your Aquamana, so I think this is a good case study as well.
It is. So since we have been publishing our cost data to the physicians, we have sidebars with certain subspecialties. So the joint doctors are on a group text where sometimes even in the meetings, my phone will start blowing up where I see that they're talking to each other about what they're seeing on the screen. And so one recently, we knew that we had one particular surgeon that uses Aquamantis in virtually every single one of his anterior approach hips. And another surgeon who doesn't do as many anterior approach, but he uses that. And so for the conversation, we brought this to the physicians and was like, there's data that's being presented to us from Avant-garde that says that we may not need to use this. So it was a very spirited group text that occurred over a period of a couple of hours. And we got the research data to them, and ultimately these doctors had decided that they weren't willing to move off of it. There's one other opportunity, but the cost is very similar. I think we talked to Beth and realized you guys are using the competitor of that. Mm-hmm. But they didn't say no, they just said they're not comfortable yet, but they were very appreciative of getting the data.
So make the data actionable and then decide how you're actually going to move forward with it. And that's a wonderful case study of, no, this is not something we want to work on. The data showed us something, but we're not going to move on it because of what the clinical staff wants to look at.
We were able to go back to that vendor and renegotiate a lower rate, though, for that.
And then Laura, you had spoken a little bit, this is going back to the vendor utilization, especially as you're trying to consolidate to one vendor.
Yeah, so this is an easy visual of vendor spend. And the trend, as you start to have more cases, your vendor utilization should increase, but we want to make sure our margin is where it needs to be.
And then Beth, this is your vendor utilization. I believe with hip, so you see a mix of Stryker, Zimmer, and Smith & Nephew.
Mm-hmm. Yeah, we are not an all-in center. We go more on the model of we want our implant costs similar, and then you can use what vendor you want.
And how similar are your pricing from implant or from vendor to vendor on the implants?
We have one vendor that's kind of an outlier. They don't like to do construct pricing with us.
Okay.
And so 3 or 4 are very comparable, and then one's a little bit more expensive. That particular surgeon saves money in other places. Mm-hmm. That makes his case cost overall similar, and so the implant cost is more, but his case costing is about the same.
Right. All right, then looking at OR utilization, again, the idea of being able to benchmark peer-to-peer within the center, also looking at that outside of your center to understand how long people are spending in the OR, what does utilization in general look like, have block utilization that we've spoken with CSMO quite a bit about, and then really understanding the revenue and profitability, on a per OR basis, if you want to go down to the minute, or just understanding how that overall rolls into your case cost. But this is with CSMO looking at an opportunity to actually decrease the time from wills into incision. Again, it's based on the 90th percentile. So you guys are at about 33 minutes. The 90th percentile is 25. Doesn't sound like a lot, but it does allow for operational efficiencies to add in another case at the end of the day or go home early for quality of life reasons. So love your thoughts on how you're looking at this and attacking it.
Sure. So keep in mind, we're 10 rooms, and today we allow our physicians to flip rooms. So that can mean that they get to leave earlier, if they're using their time efficiently. But what we are going to move to do as we're adding physicians is look at this and see, does everyone need to flip? And rather than us just saying, oh no, you're leaving at 3 o'clock, so you probably don't need all this time, or you're leaving at 4 o'clock and you should have been here till 5, is we can actually look at the data and how long a patient's in the room without the surgeon. Meaning if you're doing your lean healthcare studies, that operating room is what needs to be busy, as opposed to in the clinic, you want the physician face time with the patient to be your value added time. In the ASC setting, the time that a patient is actually being helped or at the actual operation is your value added time. So we'll be able to present that to our physicians to show who actually needs that flip as we're adding doctors. and who does not. And it doesn't make us the bad guys with that, because the data is the data.
Great, thank you. Then real quick, the fun part, just the calculations. It's actually really simple in regards to looking at, the TD-ABC or the personnel cost portion of it. So you really just have to look at what are the touch points that every individual has with that patient. So what does the care cycle look like? Who is actually doing that activity? You go everything from, you can or should go everything from check in with the receptionist to, pre-op time, who is involved in that pre-op care, then everyone that is involved in the OR, and then, post-op, et cetera, and really mapping that out. I also find the mapping is a good just understanding of how things are flowing, and it's a way of also understanding, should we be changing things based on really digging into where that patient is going when inside of the center. Then just calculating the rate, so understanding what is the cost per unit of time, and then just simple addition and multiplication. It's not overly onerous to do. You can do it internally by yourself, do it with a platform like SIS or HST or a third party like ours. You can just understand what is the personnel cost on a per minute basis, how long did that individual spend, and then what does that all in look like for that particular patient. And then again, this is just a proxy of efficiency. How long are you spending with that patient? Who is spending that time with that patient? Should we be thinking about using different personnel, or should we be thinking about doing it quicker and more efficiently?
One thing I'll say to this too is, at least today in Avant-garde, you guys use your averages, whereas for our personnel cost, we have to use that directly out of HST. So we have assigned exactly who's in the room and their rate. So we're getting exact cost for personnel with this, and it's very valuable, again, when it's on the screen with the physicians to see, for a particular case, this physician, is in the room, the surgery is this long with this amount of cost, whereas their peer, may be very, very different. So it's very valuable to have those conversations around personnel cost with this. So I'll be glad when that can be downloaded as well.
Yeah, and I appreciate that you're doing it on that detailed of a basis. Oftentimes we do the averages so that you can't pick out a particular nurse or physician, and they say, well, wait a minute, I just make more, that's why I'm costing more. So we try to average that out. But for those that are have the ability to be more transparent, it's amazing to be able to actually give the accurate cost per minute associated with the personnel.
Yeah, just one other quick point here. I use this data because we have very rich data like that as well inside of SIS, and I use that data to understand what is our actual cost as we start to have conversations around bundled total joints and going direct to employer. So that's how I actually came up with my price, because of the data that we now have access to that we never had before.
Interesting. We had one slide that showed a physician's overall personnel cost higher than peers, and when we questioned it and looked into it, this particular physician was basically demanding that we were bringing in their patients earlier, so they were spending more time in pre-op. Well, that's a cost that doctor's probably never even considered, is that when that patient is laying in one of our pre-op beds, somebody's got to be looking in on them, and that's assigned time with that staff. So that helps with those kind of conversations too, when they just want to make sure there's somebody there so that they can, between cases come out and ID and everything, there's still patients laying there, and it still takes staff to keep an eye on them during that time.
I have the exact same thing happen, because you can do this within SIS. You can do it at that level per employee, or you can do it at a role level, an average per nurse or per tech. We do that because I don't want to have to update 110 people every year. But same thing, after a meeting, a physician came to my office and he's like, why am I being charged for this? And I said, that's your nurse in pre-op, because you bring your patients in earlier than everybody else. And he's like, well, I didn't realize I was being charged for that. I was like, It's not a charge. I said, but that's part of your case cost, and it's because you don't let us manage the appropriate time to bring them in. You choose that yourself. And so it's eye-opening when you can put that kind of data in front of them.
One of the things that we were asked to look deeper into earlier this year was the cost of robotic knees. versus non-robotic knees. And, you know, when you're just mining data, that the data doesn't tell you if it's a robotic knee versus non-robotic. So through our monthly meetings with Avant-garde and their partnership with us, they have been able to add additional filters in the system. So now there is a filter where we can go and it's just a click of a button, and now we want to see the cost for just the robotic knees. So we do appreciate the partnership that we've developed with Avant-garde and their receptiveness to the additional filters that we need in order to quickly drill down to specific data.
Thank you, and I appreciate bringing up the idea of these bundles. There's interesting opportunities in groups like Carum Health and obviously other Center of Excellence programs that, you know, will negotiate with you these bundled payments and then get you out there to other, you know, self-insured employers. And we hear that the single biggest impediment to negotiating or finalizing a deal with a group or program like that is simply the center doesn't understand what price they should be charging because they don't understand their costs. Mm-hmm. And if there's cold feet on, are we gonna actually be making money on this? They often will just pass. Mm-hmm. So I think it is interesting to be able to open up a few other doors or avenues in just being able to sit at the table and have some sort of negotiation, and possibly participate in programs that your center or hospital may not have been able to previously. Mm-hmm. All right, so TDABC, this just goes back, you know, to the final and how this looks is direct contribution margin. Direct contribution margin is just the margin that is left over after your direct costs are taken out of the reimbursement. So again, that is just supplies and personnel. No overhead expenses, we're not throwing in marketing, power, lights, admin costs, because really the direct costs are the costs that you can affect on a day-to-day basis. You probably can't change drastically, you know, what you're spending on rent and all these other things. So this is just an idea of understanding case mix one, and then also understanding the contribution margin per provider, and also you can drill down. This is not drilled down to that level, but per payer as well.
Mm-hmm. Right, and with this one, I think when Laurie and I were looking at this, didn't we determine that the one kind of outlier here had to do with payer mix on this? So, yeah, but otherwise, you know, we can manage looking at those just outliers at this point, and then, you know, it's at a very high level here, and then we jump into our HST data, look at our averages, and then go down to the actual case level to see, because it could be something as simple as the staff failed to, you know, attach a supply cost, or we didn't put in a contracted rate, so it looks like we lost a lot of money on something that we didn't, or it's one of our bundles, so it just looks funny. But yeah, we like this at the higher level.
And then we're showing the same thing with Ortho Tennessee. I would say, Beth, you know, I also like this view for the ability to project out and create pro formas for interested parties. Once you have a general idea of your average direct contribution margin on a particular case, it's much easier to say, well, next year, if we grow by this number of cases by this case mix, what is our revenue going to look like? What are our costs going to look like? It does help, you know, to really paint the picture of strategy and how we're looking forward 1, 3, and 5 years.
Yeah, and this is what we are seeing now that we have gotten our total joint guys almost out of the hospital, and our Medicare volume. This is definitely a payer mix issue.
Right. And then just in closing, and then we'll take questions, just this idea of leveraging technology. Great EHR systems like SIS and HST out there that really can power this type of work. Third-party platforms like ours. You know, there's also ChatGPT if you don't want to go that route and download a bunch of data and start sorting and creating pivot tables. It can be done. You know, I know within our platform particularly, we've layered on an AI component, so you no longer have to click and always understand where the charts and reports are. You can actually just go in and say, who is the most expensive hip surgeon over the past month? It'll grab it, it'll show you, it'll give you the pricing. You can drill down to individual supplies as well. Who is using the most Aqua Mantis? You don't even have to go search, you can just search for there. But there's a lot of wonderful tools that I think we can be utilizing that aren't incredibly expensive. Frankly, a lot less than having one person hired on at the center to do all that work, unless we're like you and can do a lot of the statistical analysis. But yeah, use technology to its fullest, and go down this route of really understanding your costs and being able to optimize and implement new strategies to reach those higher EBITDA margins that we saw at the very beginning. You want to stop and open it up for questions if there are any?
First, thank you all. A round of applause from the audience. Excellent work. And I want to just shout out to our sponsors, CIS and HST, who've been great collaborators with our members and also with Avant-garde in trying to create a situation where when you don't, I think Beth is a great example, when you don't necessarily have the time or the resources internally to create what is available within the system, to have a partner, and they have done a bang-up job in working with you, correct, Dr. Eccles?
They've been wonderful,
Yep.
yes.
So I appreciate that. I have a lot of questions. One of them from the audience is, anybody benchmarking, both in the audience and at the panel, is anybody benchmarking their facilities against each other? And you also, Porter, work with people who benchmark their facilities against each other, so anybody?
When you're saying facilities, are you talking strictly facility cost or overall? Like
ASC to ASC.
No, we're looking forward to getting that benchmarking through the Ortho Forum again, so that we can, have some comparison. But really, it's just, I think that we have so many phone a friends within Ortho Forum and Ortho Connect that we're picking up the phone and calling and saying, we see this. But now, especially when we have, things that show through HST and others, that we need to look at it. That's how we're doing it.
I appreciate that.
Sorry. We do that within Ortho Tennessee because we have two centers, and so we actually have our meeting monthly with Avant-garde together.
We're a little bit unique in Maryland. We are part of an EQUIP program, which gives us data exposure to the entire state and those contributing to the program. Essentially, it's data 3 days prior to surgery all the way to 90 days post-surgery, total cost of care. It allows us to benchmark amongst other participants in the program, but also gives us realization of what it costs for the same procedure in the hospital setting versus our ASC. And to complement Andrew's conversation yesterday around payer contracting, this is the complement here. Understanding your data allows you to go back to your payers and have a much more robust and meaningful conversation. So just
Absolutely.
share that.
That's perfect. One thing I would also just, because I've been doing this for a long time and I'm pretty grown up because of that, is that in the past we had a lot of space to allow physicians to sort of exercise their artistic license to do what they wanted to do. Now, when you've got physicians who are operating outside of what is the norm for your center, and you can make that visible to them, it really is your fiduciary responsibility to make them aware of it. That's really our responsibility, because we're dealing with recruitment and retention issues, and every dollar that goes out because of a consulting arrangement or just not being aware of how they are operating based on their peer group, every dollar that goes out is a dollar that you could be using to support better staffing, to support actually having an electronic health record like CIS and HST, inviting other partners for technology like Avant-garde. And they're not aware of it necessarily. I loved your comment, Kimule, about assume good intent, because they're not always aware. And if you can make it visible. The other thing that I took away from this is this whole idea of crucial conversations. I don't think most of us are equipped because we don't come to these environments necessarily as skilled negotiators or skilled conflict resolution people, but we need to invest time in those skills. They're really important. So, anything else from the audience? Oh, is there an ability to work with Epic? Do you work with Epic?
We do work with Epic. We don't have a direct integration like we've been able to create with HST and CIS, but almost all of our hospital clients are on Epic. So
Okay.
we're very familiar with that.
Here's one more. See, people get busy when the meeting comes to Q&A. Would you share the average difference in total cost you're seeing between total knee robotic versus non?
We can share that. We can pull that data up and we can share it. We can get it to you, Karen, and then
Okay, great.
get that
That's great.
published.
I can share our experience. We have a Mako in our ASC. The reality is we have capped pricing, so I don't really care. If the vendor meets the number, I don't care if it's robotic or non-robotic.
That's great. And again, this goes back to negotiation, because you can have lots of data, but if you're not really equipped to negotiate, we will spend some time on that in strategic services and maybe even a virtual meeting. I think that's it. Thank you so much.